Okay, uh, good evening, class. Welcome to our session on CNS and Parkinson's disease. We said Parkinson's disease is a chronic progressive disorder of the central nervous system. The symptoms that we see in patients with Parkinson's disease occur due to a deterioration. It comes as a result of deterioration of dopaminergic neurons in the substantia nigra, and this affects the peripheral nervous system. So the substantia nigra is a part of the brain. Substantia means substance, and nigra means black. So this is an area of the brain that is stained with a dark color, and it's given the name substantia nigra. And this area is normally responsible for the production of the dopamine. And we are going to see the effects of dopamine on the skeletal muscle. So what happens in Parkinson's disease is that there is a deterioration of the dopaminergic neurons. Those neurons that are supposed to produce this dopamine, they are damaged and they deteriorate and they are not producing this dopamine. And therefore, the effects of this are also seen in the peripheral nervous system, and that's why you see this patient manifesting with muscle-related disorders as a result of this particular pathology in the central nervous system. Normally, in the normal person, there is a balance that exists between the dopamine, which is an inhibitory neurotransmitter. Dopamine is a neurotransmitter that inhibits the action of muscles, okay, and acetylcholine, which is an excitatory. So actually, the two counteract each other. So there is a release of dopamine, and also there is a release of acetylcholine within the synaptic cleft, and this balance keeps us able to control the voluntary movements of the muscles. So if there is a misbalance and then inhibitory overpowers the excitatory, or excitatory overpowers the inhibitory, and then muscle movement will always be affected, basing on which direction is the most predominant one. Okay, so this abnormality here leads to a depletion of dopamine along the nigrostriatal pathway and causes progressive neurological deficits. So let's look at the motor symptoms. What motor symptoms do patients with Parkinson's disease present with? We say dyskinesia, that is bad movement, actually, motor movement disorder. Okay, dyskinesia is then the person is not moving in the normal way. I remember we used to have one person for those who have stayed in Juba around Haitrawa area. There was an old mama with this disorder of Parkinson's disease. Normally, she moves as if she's running, and the village got to know her and describe her with the name of this woman who always moves running. But actually, the woman is not moving running. What has happened is that she's suffering from Parkinson's disease, and the movement is already in such a way that she moves like small steps that are faster, and it's difficult to control movement. It's like there's no break. Okay, you start movement, it's difficult when you start movement, but once you start movement, also it is difficult to stop. So this is basically what happened. They also have tremors, okay, and then there's also rigidity. So rigidity is like when the person is sitting and is trying to stand up, is facing difficulty, he uses a lot of effort, but also after standing up, even if you want to start a movement, sometimes it takes an effort. If this person start moving and then suppling steps, fast movement, but also if he wants to stop, it's a difficult thing because the braking, okay, the speeding process and also the braking process is already compromised because there is that imbalance between the excitatory neurotransmitters and also the inhibitory neurotransmitters that we already talked about, the dopamine and the acetylcholine. They also have slow movements called bradykinesia. Brady means slow. Okay, and then there's postural instability. So you find their posture is not stable because the muscles are already affected and they cannot keep a stable posture. Now, we also have the non-motor symptoms. The non-motor symptoms, always these people have altered sense of smell. Okay, they lose some smell. They are not able to smell certain things because that threshold is lost. There's also excessive salivation, some kind of drooling, because muscles are already compromised. So, yeah, control of saliva is also affected. There's hand clumsiness and also poor handwriting. Already we write because of the motor activity, the voluntary activity that our muscles can do. But in this, already the muscles are affected. So some people always start with worsening of the handwriting. Actually, somebody sees that they start having tremors that sometimes we don't see them, but they start to feel it as an early stage of Parkinson's disease. And then as time goes, somebody realizes he's not able to write well, and the handwriting is worsening, and then more and more it graduates, and more symptoms come out. There's a slowed gait, okay? The gait will be a slow one. Somebody moves with slow steps, reduce voice volume. All this just because of these axons at the neuromuscular junction. Okay, brain neurotransmission in normal movement. What happens in the normal person? Normally, this involves structures in the extrapyramidal system in the brain. Extrapyramidal system is the part where that is concerned with the control of this voluntary uh, movement of the muscles. Control movement is regulated by the globus pallidus, also via a neurotransmitter called GABA, which is gamma aminobutyric acid. So this is one of the important also neurotransmitter here. And then two neurotransmitters in the striatum. So striatum is also a specialized area of the brain. So all these are specialized area of the brain that produce that perform specific function based on the neurotransmitters that are stored in them. So in the striatum, we have the dopamine and acetylcholine, which regulate the release of the other neurotransmitter called GABA, gamma aminobutyric acid release. So normal movement when dopamine and acetylcholine are balanced. So always we are able to move well because our body systems are able to keep the balance between dopamine and then the acetylcholine, which is excitatory. This is inhibitory. Okay, now let's look at brain neurotransmission in Parkinson's disease. What happens here? The underlying cause is a slow loss of dopamine neuron in the black area, the substantia nigra area of the brain. The imbalance of excess acetylcholine and GABA leads to motor symptoms. So what happens is that dopamine is inhibitory, it inhibits muscles action. But then since dopamine is lost, and we have excess acetylcholine, whose action is to excite muscle, okay, and even GABA, which acts the same, in the same line, they excite muscles, and then there's already motor symptoms, and there's hyperexcitation of muscles out of control because there's nothing that inhibits that excitation. The causes of dopamine neuron loss is unclear. We really don't know what causes that degeneration, but it happens in people with this disease. And they have said that defective brain proteins like the ubiquitin might have caused increase in what we call alpha synuclein. They said people with this disease are found to have this kind of finding. So probably this is one of the reasons that explains why they're having these particular symptoms. Also, they are saying genetic vulnerability or environmental toxins might have also contributed to this disease in this particular person. Antipsychotic drugs have also been implicated here, okay, in causing Parkinsonism, that is the extrapyramidal symptoms we see. So sometimes the mentally ill patients or the psychotic patients, once we put them on the antipsychotic medication, especially the typical psychotics, you find most of those drugs have the extrapyramidal side effects, and then you see this person is developing some tremors that are just a bit difficult to control. Let's look at what are the treatment goals. We have already looked briefly about what Parkinson's is and what leads to it, but then how can we treat it? We know very well that there is no cure to reverse or prevent the neurological degeneration that already exists. But then the current drugs regimens aim to improve just the activities of daily living of this particular person, ADLS and so on. And normally what is done is just symptomatic relief. Medications cannot cure or delay the progression, but at least to minimize the to improve the symptoms, and then the person is able to manage activities of daily living. Drug treatment of Parkinson's disease, the strategy is to boost the dopamine. We said dopamine was being depleted, so we have to give dopaminergic drugs. by replacing dopamine replacement therapy. Or we give dopamine agonist drugs that support the actions of dopamine. Or we give drugs that prevents the breakdown of dopamine within the synaptic space. So these are other ways. These are indirect ways. So dopamine breakdown inhibitors so that dopamine is present, or we give dopamine agonists, drugs that increases the actions of dopamine. And then we also have drugs that increase the release of dopamine. So from the synaptic, within the synaptic space, we can have drugs that will increase the secretion of or release of dopamine in the space, and then so that muscle balance is a bit sustained. Uh, Also, we have drugs that we give to increase acetylcholine. We say that acetylcholine was the counter of dopamine. So if we have drugs that can also increase this, because we are lacking dopamine, it will also help bring some balance. Dopamine replacement becomes less effective normally after 2 to 5 years. So you can see we only just have a narrow window really of this particular replacement. Dyskinesias and on and off phenomenon are very common challenges. Drug treatment still of Parkinson's disease continuing. We said anticholinergic drugs act in the central nervous system. The first treatment was in 1867 by this person called Jean Martin Charcot. This was a major breakthrough discovery. Levodopa was first used by Arvid Carlson in also 1961. Then anticholinergic uh, block muscarinic acetylcholine receptors in the striatum. Examples here is what we call benzotrophin and also trashexapentine. You will also get to know this one of the common antipsychotics we use even for patients with schizophrenia and other mental disorders. Multiple side effects can be dry mouth, blood vision, photophobia, urinary retention, constipation, and also tachycardia. There's a safety alert here that we have to avoid this in elderly due to CNS side effects like sedation, confusion, delusion, and also hallucinations. The non-motor symptoms and their treatment, we said sleep disturbance is a bit common, excessive daytime sleepiness, periodic limb movement of sleep, okay, insomnia, that's absence of sleep. Treatment, we have the drug called modafinil, and also, treatment for excessive day sleep, we said we can use modafinil, and also for periodic limb movement, we said levodopa and carbidopa can help, or pramipexole and rofinirol. For insomnia, we can also use the same levodopa or carbidopa or melatonin. Depression effects, depression, we say depression affects 50% of this particular patients. And the treatment is also the antidepressants. Dementia occurs in about 40% of patients with Parkinson's disease. The treatment we can use for this dementia is the cholinesterase inhibitors. One is donepezil or rivastigmine, which is also used for Alzheimer's disease. The modest improvement observed, and then there's by psychosis occurs in 20% of the patients, and then also we have visual hallucinations. Dreams of visual hallucination means the person sees things that really a normal person cannot see, but he's already telling you what he's seeing. Dreams, nightmares, and paranoia. Paranoia sometimes they just become detached, quiet, and not talking. Caused by dopamine receptor activation in the wrong place. That's what might trigger this. The treatment is second generation antipsychotics with little dopamine agonist blockage in the striatum. Still continuing with this treatment, we have the drug called pimavanserin for Parkinson's psychosis. Okay, it was approved in 2016 of recent. We have also the inverse agonist of serotonin 2A, 5-HT2A receptors. Most antipsychotic medications worsen motor dysfunction due to dopamine antagonism. Blood box warning, this is just for you, for your own person. It said there is increased mortality risk in elderly patients with dementia-related psychosis. Prior results indicate reduced hallucinations and delusions without worsening motor symptoms in PDP patients. Additional studies ongoing for Alzheimer's psychosis and schizophrenia and also insomnia treatment. With this, we have come to the end of this session, and thank you for being with me, and see you again.